Okay, so good day everyone. Today is our first topic for the finals and we'll talk about the immunodeficiency diseases. Okay. So for this particular meeting, we will be discussing the primary immunodeficiencies and as we compare them to secondary immunodeficiencies. We will also be discussing classification of primary immunodeficiencies, immunologic defects in selected immunodeficiency diseases, and what are the different laboratory assays or tests that we can actually utilize to diagnose immunodeficiency. So let's define first, what do we mean by immunodeficiency? Immunodeficiency is defined as disorders in which part of our immune system is either missing or dysfunctional. So when you say dysfunctional, some part of our immune system or some components of our immune system is not functioning well as expected. So can you imagine there is a condition known as lazy phagocyte, wherein a phagocyte is not doing its job, which is to phagocytize foreign matters. As a result, there would be what? Decreased ability to defend against infections, and more so, we become susceptible to develop malignancies or cancer. As a result, we can actually divide our immunodeficiencies into two. Either we have the primary immunodeficiencies, otherwise known as PIDs, not to be confused with pelvic inflammatory disease, and the other one is secondary immunodeficiencies. So when we say primary immunodeficiencies, it is something that is inherited, meaning to say it is something that is congenital. We are genetically predisposed to get PIDs. So it could be attributed to the X-linked chromosomes, or it could be due to autosomal recessive or autosomal dominant genes. Now, on the other hand, when we say secondary immunodeficiencies, we are referring to something or a disorder that is acquired as a result of condition such as infection. So we will have a separate chapter when we discuss HIV. Secondary immunodeficiencies may be also due to autoimmune diseases, malignancies, and if you are drinking immunosuppressive drugs, because immunosuppressive drugs will actually make your immune system less functional so that it will not reject the newly transplanted or grafted organs into your body. So for this particular topic or for this particular session, we will be focusing more on primary immunodeficiencies. Okay, so the immune system components that are affected by the primary immunodeficiencies are actually, there are actually three components. Number one is humoral immunity. So this is the first component that is affected. Okay, so the humoral immunity. So it is caused by defects in B cells or T cells. Now, if you do recall humoral immunities, this primarily involve mature B cells, which would become plasma cells. And the main function of plasma cells is for secretion of antibodies. On the other hand, when we say cell-mediated immunity, this is primarily the T cell deficiencies. So patient would become susceptible to intracellular pathogens. Unlike when we say humoral immunity, patient would be simply susceptible to bacterial infection. Okay. So as a result of humoral immunity, patient may get sinusitis and otitis media. Okay, sorry for that. Now, when we say innate immunity mostly involve neutrophils or macrophages. Okay, um, neutrophils or macrophages. These two are important for phagocytosis. So the ability to cell to phagocytize foreign materials would result to patients being more susceptible to bacterial infection. And also, some patients would have deficiencies of complement component. So, for example, some patient may be deficient with C3, which is the most abundant complement component. So, they would be more susceptible to bacterial infections and autoimmune diseases. Okay, so again, these are the three components that may be affected by primary immunodeficiency disorders. Okay, so they say that a picture paints a thousand words. So this particular picture would tell us a very significant story. So this first picture that we have here refers to the normal proliferation of the cells of the immune system. So the PS here represents pluripotential cell, and pluripotential means that it potentially becomes any other cells of our body, could give rise to our CMP, the common myeloid progenitor, and the common lymphoid progenitor, or the CLP. So what does it tell us? Sorry, what does it tell us? So let's say, for example, that the common myeloid progenitor is affected. Okay, common myeloid progenitor could give rise to, this is the neutrophil, and then this is the natural killer cell. Okay, so if you have problems with maturations of neutrophil, then chances are you can get CGD, which stands for chronic granulomatous disease, or LAD, leukocyte adhesion deficiencies. Now, if you have, for instance, you have here the pluripotential stem cell, and pluripotential stem cell is supposed to mature into common lymphoid progenitor, and this will give rise to the natural killer cell. But somewhere along the way, there is a problem in the maturation of the natural killer cell. Then chances are you might possibly get CH, or Chiari-Higashi disease. Okay. Now let's talk about further about common lymphoid progenitor. The common lymphoid progenitor could give rise to immature B cell and immature T cell. Okay. If some if somewhere along the way you have problem with the maturation of immature T cells, then these are the diseases that you can possibly get. You can get the George anomaly. You can get PNP, which stands for purine nucleoside phosphorylate deficiencies. And you can even get WAS, or the Wiskott-Aldrich disease. Okay, now here, this is the common lymphoid progenitor. So again, if somewhere along the way you have problems for the maturation of IT, and this one is IB, which stands for immature B cell disease, then you can actually get the so-called combined deficiencies, meaning to say you do not have just problem with immature T cells, but you also have problems with immature B cells. Okay, the normal maturation of immature B cells and immature T cells. So these are the possible combined immunodeficiencies, meaning to say you have problems with both T cells and B cell deficiencies. So this would include AT, which stands for Atexia telangiectasia, and then ADA, which stands for adenosine deaminase deficiency. And then we also have the JAK3, which is the Gynous kinase 3 deficiency, and the XSCID, which stands for the X-linked severe combined immunodeficiency syndrome. Okay, so these are actually some of the worst immunodeficiency disorders, because you have a deficiency of both immature T cells and immature B cells. Now, if somewhere along the way, okay, you have you have problems you have problems with immature B cell maturation, particularly maturation into PS, which stands for pluripotential stem cell. Then you can have CVI. CVI stands for the common variable immunodeficiency, wherein, of course, since you are having problem with pluripotential stem cell, um, you might possibly have problems in forming immunoglobulins such as these IgM. Now, if for example, you have another problem with maturation of PS, another pluripotential stem cell, you can also get IgG deficiency or a particular subclass of IgG deficiency. Not only that, if you have problems again with pluripotential stem cell, okay, you can even get IgA deficiencies. Okay, so guys, from this part, okay, up to this part, these are exclusively B cells deficiencies. This part, these are exclusively T cell deficiencies. Okay, so imagine, no, if you have problems with pluripotential stem cells, you can get several kinds of immunoglobulin deficiencies. So primarily speaking, meaning to say, um, you will not be able to produce enough antibodies. Now, lastly, if you have problems with CD40, okay, CD40 is very important. It is our marker for stem cell marker. Okay, so CD40 is our marker for stem cells. So you'll not be able to have proper maturation of cells such as this particular T helper cell, and T helper cells are important in both the maturation of immature T cells or for the functions of the cytotoxic T cells and even for the functions of plasma cells. Okay, so there you have it. So these are the possible kinds of immunodeficiencies. These are the possible kinds of immunodeficiencies that you can possibly get if you have problems in maturation of any components of the cells of the immune system. So moving further, we can therefore categorize PIDs into nine. So we can have combined immunodeficiencies, okay? And then combined immunodeficiencies with associated or syndromic features. And then we can also have predominantly antibody deficiencies. And then disease of our fourth one is the disease of immune regulation. Okay, fifth category is congenital defects of phagocyte number, function, or both. Number six would be defects in innate immunity. Number seven is autoinflammatory disorders. Number eight is complement deficiencies. And number nine would be phenocopies of primary deficiencies. So we will only be discussing some of the most common types of immunodeficiencies. Okay. So to start with, let's start with predominantly antibody deficiencies. So obviously, when you say predominantly antibody deficiencies, it means that we have low levels of serum immunoglobulins. In fact, the prefix "a" refers to the absence of. So which means that a gamma globulinemia is the absence of gamma globulins. And what are the importance of gamma globulins? Gamma globulins are actually the primary protein components. These are the primary protein components of antibodies. Okay? So this will involve genetic defects in B cell maturation or defective interactions between B and T cells. So predominantly antibody deficiencies may involve all immunoglobulin isotypes or one subclass only. So here we compare patients' immunoglobulins with age-matched reference age. What does it mean? Age-matched reference age, because the reference range or the normal values of immunoglobulins in our body depends on your age. Okay, so it depends on your age. So for example, neonate will not be able to produce it's his own antibodies yet. So his level will be different from that of toddlers or even with that of the adults. Okay. So let's discuss some of the examples of predominantly antibody deficiencies. And them is one of them is the Bruton, okay, Bruton's agama globulinemia. Okay, so Bruton's agama globulinemia. So the Bruton's gamma globulinemia is actually an X-linked, okay, tyrosine kinase. So that's the reason why it's called BTK deficiency. Okay, so here the marker is actually the BTK gene, and it is found at the Q arm. This is of the long arm of chromosome X. Okay, so that's the reason why it is an X-link. So primarily known as the XQ21. Okay, now if you are a female, most likely you are a carrier, meaning to say you do not phenotypically express the BTK gene. Why? Because females would have double X chromosomes. So even if one of the X chromosomes would have BTK gene, there's another X chromosome that is normal, and this would be dominant. Hence, the other X chromosomes will not be phenotypically expressed. So that's the reason why majority of the female will just be a carrier. However, for male would have the XY chromosomes. And if the X chromosome of male is affected and he doesn't have another X chromosome, so the BTK gene will be expressed. Okay? So what will happen? There would be arrested maturation at the pre-B cell stage. And then that particular child wouldn't have mature CD19 plus B cells in blood, plasma cells, and in lymphoid tissues because these are important for the proper maturation of B cells. And this patient should be treated with gamma globulins because this patient would really lack these particular proteins to make up antibodies. Okay? So common variable deficient immunodeficiencies is another example of predominantly antibody deficiencies. Now, this, on the other hand, is a heterogeneous group of disorder which can be congenital or acquired, and symptoms begin between 20 to 30 years of age. So, meaning that child uh, was able to we had a chance to grow from 20 to 30 years of age. Unlike if in X-linked, it's quite difficult for that child to mature properly, no? So there is a failure of B cells to mature into plasma cells as a result of B cell or T helper cell defects. And again, these are being treated with gamma globulin. Okay? Because the condition is known as the gamma globulinemia. So the term gamma globulinemia means lack of gamma globulin, a protein needed, okay, for the formation of antibodies. And then we also have another one. Okay, so we have the predominantly antibody deficiencies. This is now the another examples are number 3. This is the by the way, these are our third disorder. We have the transient hypoglobulinemia. So the word transient means temporary. So it is not something that is permanent, which means that there's only a delayed development of immunoglobulin production, especially IgG. So here you have normal number of B cells, but delayed maturation of T helper cells. Okay. So I think this one is much better as compared to the X-linked brutons, a gamma globulin unit. And then the fourth one is the selective IgA deficiency. So obviously, the only immunoglobulin that is affected here is IgA. So you will have low level of IgA, perhaps because of impaired differentiation of IgA plasma cells. So patients may be asymptomatic or more susceptible to infections, allergy, and even autoimmunity. Okay, so that is the fourth example. Okay, fifth example of or fifth disease and or fifth disorder under this category is the IgG subclass deficiency. Now, this particular deficiency um, would be only affecting would only be affecting IgG obviously. So there would be what? There would be mutations in IgG heavy chain genes. Now, let us recall what is the importance of heavy chain. Heavy chain is actually important because this dictates the class of immunoglobulin. Okay. And then the sixth disorder under this category is the CD154. By the way, CD154 is also known as the CD40 ligand, meaning to say, or the sometimes you will CD40L, meaning to say when you say ligand, this is where the CD40 will actually attach to. Okay, so it is a protein that is primarily expressed on activated T cells and is a member of the TNF, okay, tumor necrosis factor superfamily molecules. So the reason why we call it CD40 ligand because it binds to CD40 on antigen presenting cells. Okay? So CD154 will bind to CD40, particularly in antigen presenting cells. Okay. Now, if we are deficient with CD154, there would be decreased levels of IgA, IgG, and IgE as a result of defect in B cell switching. B cell switching is important. B cell switching is important so that you'll be able to properly produce immunoglobulins such as IgG, IgA, and Ig. So by the way, this is the CD154 or the CD40 ligand, and this is where the CD40 will bind to in antigen presenting cells. Okay, so let's talk about combined immunodeficiencies. So the combined immunodeficiencies will involve um, not just T cell deficiencies, but it would also involve B cell deficiencies. Okay, so it will involve both T cells and B cells deficiencies, and it will affect complex. Okay, it will affect the cell mediated and humoral immunity. Okay, and possible treatment would be bone marrow transplant to reconstitute the immune function. Okay, so primarily involve T cell deficiency. Okay, so let me correct myself. It primarily involves T cell deficiency, but it will affect both T cells and B cells. So that's what I meant. Okay. So if T cells are affected, then the cell mediated immunity will be affected. If B cells are affected, then humoral immunity would be affected. So this is an example of a bone marrow, okay, bone marrow aspirate or transplant, okay, so that we need to reconstitute the immune function. Um, one of the one of the examples of combined deficiencies is the SCID. Okay, so the SCID is otherwise known as severe combined immunodeficiencies, and it involved a defect in normal T cell development. However, even if it only involves defect in T cell development, it may affect both the B cells and natural killer cells. Okay, so there's another type, which is the X-linked recessive form. So this one is caused by interleukin RG gene mutation, and the other one is the autosomal recessive forms associated with various defects. Okay, so again, when we say X-linked, primarily a defect in X chromosomes, so majority of the female would be a carrier, while males would be affected. Okay, so I have already explained why so. And then for autosomal recessive, okay, both the both male and female could be carriers. So if a carrier father, okay, copulates with a carrier mother and the progeny could have 25% um, child which is affected, and then 50% of their children of the progeny could be carrier, and only 25% could be normal or unaffected. Okay, so in autosomal recessive disorder, it means that both male and female could be a carrier, unlike in X-linked recessive, only the female could be a carrier, or most of the time, male would be affected. But in autosomal recessive, both sexes could be affected by this particular disorder. So this is a sad story of a bubble boy because he lives inside the bubble. So this boy has a condition known as the SCID, and he needs to live in a sterile environment because being exposed outside the environment could be fatal for him. Okay, so so to illustrate, this is the picture of a healthy appearing child, wherein this child would have a normal T cell production, unlike this one. They have a very low. This child has a very low or absent in T cell production. So as a result, T cells functions would be not normal for a patient with SCID. Okay. Now we also have another one, which is the Wiskott-Aldrich syndrome. It's another type of X-linked recessive primary immunodeficiency disorder. And this one is characterized by immunodeficiency, eczema, and thrombocytopenia, okay, or deficiency in the number of platelets. So in Wiskott-Aldrich syndrome, you would expect that platelets would be excessively or extremely small, okay, and low in number. So there is a defective T cell function, and as a result, there would be a decrease in IgM, normal IgA and IgG, and increase in IgE. So there is a defect in CD43. So remember, in Wiskott-Aldrich syndrome, there would be a defect in CD43, an integral membrane protein needed for signal transduction in lymphocytes. Okay, so another example of deficiency is the George anomaly. So the George anomaly is developmental abnormality in third and fourth pharyngeal pouches in the embryo. So this actually affects the thymus development, and most patients would have deletion in chromosome number 22. Okay, as a result, there is the underdevelopment of thymus because of the abnormality in the third and fourth pharyngeal pouches in the embryo. So there would be underdevelopment of thymus and decrease in T cells. So hypoparathyroidism and hypocalcemia would also be very evident in this kind of patients. Cardiac abnormalities, mental retardation, and abnormal facial features. So it's another sad story for patients with the George anomaly. And then Atexia telangiectasia is another example of a rare autosomal recessive disorder. Atexia refers to involuntary muscle movement, while telangiectasia is a capillary swelling with red blotches on the skin. So here we would expect patients to have low number of T cells and defective antibody response. So Atexia telangiectasia will involve mutations in AT gene, particularly on chromosome number 11. As a result, there would be defective DNA repair and gene rearrangement in T cells and B cells. So these are examples of a child with Atexia telangiectasia. So there would be involuntary muscle movement. So and then telangiectasia, you'll see blotches in the skin, and of course another and radiation sensitivity. So these are the symptoms of having the AT, Atexia telangiectasia. And then there could also be a defect in phagocytic cell function, such as in cases of chronic granulomatous disease. So this is a group of disorders inherited as X-linked recessive or autosomal recessive. Here, neutrophils are unable to generate oxidative bursts. Oxidative bursts are important. Oxidative bursts are important so that neutrophils would be able to do its function during phagocytosis. So oxidative burst or failure to generate oxidative burst is a result of genetic defect in the component of the NADPH oxidase system. Meaning to say, neutrophils will not be able to phagocytize organisms that are catalase positive. So catalase positive organisms would include Staphylococcus, and even Bacillus is catalase positive. So in the laboratory, we can determine whether the patient would have the so-called CGD by doing the nitroblue tretazolium test and DHR, which stands for dihydrorhodamine acid. Okay, so that is the chronic granulomatous disease. So here's how MBT works. So it's a semi-quantitative assay. So we test the ability of the neutrophils, otherwise known as the PMNLs, polymorphonuclear leukocytes. Okay, so what will happen is that after we have added nitroblue tetrazolium into the smear with neutrophils, it should reduce colorless into a colorless NBT with a blue-black deposit within the cell. Okay, so it becomes colorless. However, in CGD, the PMNLs will not, the neutrophils will not turn into blue. So, so this is how the normal thing, normal cells, no? So it will become colorless, and then there would be deposits. But if a person would have NBT, there won't be any blue deposits. Meaning to say, that particular patient lacks the NADPH oxidase system. Okay, now let's talk about complement deficiencies. Majority of complement deficiencies are inherited as autosomal recessive disorder. And there are deficiencies in early complement components. Meaning to say, it is associated with a lupus-like syndrome. C2 deficiency is the most common example of complement deficiency, though C3 is the most abundant complement, no? So if C3 is defective, then it would be associated with recurrent infections, particularly with encapsulated bacteria, such as Neisseria meningitidis. Is an example of encapsulated bacteria. Now, deficiencies in late complement components will also result in Neisseria meningitidis. Okay? Deficiency in C1 esterase inhibitor will result in 2 hereditary neuroangioedema. Okay, so these are examples of complement deficiencies. So in the laboratory, these are the things or clinicians would usually do these steps in screening for immunodeficiency. Of course, it's very important for him to determine the history of the patient. And basic test is to do CBC, wherein when a clinician asks for CBC, we medical technologists would also be doing the WBC differential count. Then physicians would even be requesting for the serum levels of IgG, IgM, IgA, and even subclasses of IgG. Then he would also be requesting for isohemagglutinin to determine the natural ABO antibodies and to determine the antibody response after vaccination. So most of the time, patient with this kind of history won't have enough response after vaccination. So here, there would be delayed hypersensitivities, skin reactions for cell-mediated immunity. So for the determination of complement deficiencies, um, clinicians would be requesting for the CH50 assay and then DHR assay for neutrophil function. So these are some of the basic screening procedures, okay, for immunodeficiency. However, for confirmatory tests, we might want to study a particular marker of a certain cell. Okay? So we can do immunophenotyping or flow cytometry to determine the level of B cells, T helper cells, cytotoxic T cells, and even natural killer cells. And of course, um, genetic testing. We can do karyotyping. We can do molecular techniques to determine to confirm what particular immunodeficiency is present. Now, there is one mitogen assay for T or B cell proliferation. Why? Mitogen is a chemical compound that we usually add, okay, to stimulate mitosis in all T cells or B cells. So here, would be able to study the normal cell proliferation or division of the patient. So other assay available for T cell activations would include quantiferon, TB, and T-spot, and then measurement of gamma interferon by T cells activated by Mycobacterium tuberculosis, and then the cyclex. So this one, Silex, sorry. This one is the immunoassays, which measures the ATP production from mitogen activated T cells. And then, of course, to really confirm if a person has a deficiency in antibodies, the level of antibodies, then we can do the evaluation of immunoglobulins. So we can quantify immunoglobulins via nephelometry, radial immunodeficiency, or in this particular picture, this is otherwise known as the SPE or the serum protein electrophoresis. This one is actually more accurate way of determining the level of antibodies and the immunofixation electrophoresis. Okay. So, and of course, newborn screening is important. We can determine the T-rex or the T cell receptor excision circles during the newborn screening. So T-rex are supposed to be produced as a byproduct of TCR rearrangement as shown here. Okay. So we can actually determine this by quantifying it through PCR. Why is it important? T-rex are important, not the dinosaur, okay? T-rex, because it will reflect the number of T cells. And in the United States, it is mandated by many states. And this one will tell us whether the patient or the neonate would have T cell deficiencies such as the SCID. Okay, so there you have it. That's the end of our discussion for immunodeficiency. Thank you everyone for listening.